All right, let's jump right in. Today we're going to break down the latest evidence-based guidelines for bringing digital pathology into your lab, safely and, effectively. If you're anywhere near this digital transformation in pathology, this is definitely for you. So this is really the fundamental question, isn't it? It's what the College of American Pathologists, or CAP, set out to answer with their latest guideline update. The whole point isn't about whether digital is somehow better, but can we trust it to be at least as accurate as the gold standard we've all been using for, over a century? And just so you know where all this is coming from, the recommendations we're about to dive into are straight from this key document. It was a huge collaboration between CAP, the American Society for Clinical Pathology, and the Association for Pathology Informatics, and it's all built on a really thorough review of the latest evidence. So why is this such a big deal right now? Well, whole slide imaging, WSI for short, is really moving out of the research world and into routine diagnosis. That means standardized validation isn't just a nice-to-have anymore, it's absolutely essential for patient safety, especially now that the FDA is clearing WSI systems for primary diagnosis. Having a clear roadmap is just critical.
Okay, so what are we even talking about when we say validation? The guideline defines it as this formal process to prove the system works exactly like it's supposed to, but, and this is key, in your specific lab, your environment. The goal is pretty simple. Make sure pathologists can make diagnoses with WSI that are at least as accurate as with a microscope, and at the same time, spot and control for any new risks the tech might introduce.
All right, so the expert panel basically took years of research and boiled it all down into 3 non-negotiable evidence-based recommendations. Let's get into these, because they're really the pillars of the whole guideline. These 3 steps, getting your case set right, measuring concordance, and having a proper washout period, they really form the basic structure of any solid WSI validation study. If you get these 3 right, you're in great shape. First up, the case set. Your validation has to include a bare minimum of 60 cases. And listen, it can't be just any 60 cases. They have to reflect the complexity and the variety of your lab's actual day-to-day workload for whatever you're validating, like H&E stain sections, for example. And that number, 60, it isn't just random. The evidence actually shows that concordance rates don't really get better just by adding more and more cases. Second, the performance benchmark. You've got to show an intra-observer concordance rate of over 95%. What does that mean? It means the exact same pathologist, looking at the exact same case, comes to the same diagnosis on both the glass slide and the digital image more than 95% of the time. And third, the process itself. There has to be what they call a washout period of at least 2 weeks between when a pathologist looks at the glass slides and when they look at the digital versions of those very same cases. This is so important for minimizing recall bias, Otherwise, you could accidentally make your concordance scores look way better than they actually are. Okay, that 95% figure is the big headline number, right? So let's take a minute and unpack exactly where it comes from and what it actually means for your lab in the real world. Now, this is a really important idea to get your head around. An intra-observer study is not designed to retest a pathologist's diagnostic skill. Nope. Instead, it's meant to isolate one single variable, the technology. The only question we're trying to answer here is, does switching from a glass slide to a digital image introduce errors or change how we interpret things? That's it. And this chart really shows you the evidence behind that 60 case minimum. See, in their big review, the studies with fewer than 60 cases had a noticeably lower mean concordance. But as soon as you hit that 60 to 200 case range, the rate just stabilizes right around 93%. So just piling on hundreds more cases doesn't necessarily make your validation any better. So then, where does the 95% target actually come from? Well, it comes directly from the literature. The panel calculated a weighted mean concordance of 95.2% across all 33 studies they included in their review. So you see, it's not some magic number. It's the evidence-based average performance that you should really be aiming for. Okay, so what if you don't hit that 95% mark? Is it an automatic failure? Absolutely not. The guideline actually frames it as a trigger, a signal to start investigating. You need to go back, reconcile every single discrepancy, and look for patterns. Is it one specific type of case, an issue with the scanner, maybe poor histology? The goal is to find the root cause, fix it, and maybe just keep those tricky case types on glass until the problem is solved. All right, so beyond those 3 big, strong recommendations, the guideline also gives us 9 good practice statements. You should think of these less like hard and fast rules and more like an essential playbook for running a really smooth and successful validation.
The easiest way to think about these statements is to group them into three logical buckets. First, you've got setting up your system and scope. This just means you validate the whole workflow for a specific task, say for frozen sections. Second, running the process with the right people. This is all about making it realistic, using staff who are already trained, and randomizing the case order. And third, maintaining quality and compliance. This covers things like change management, making sure the entire slide was captured in the scan, and of course, documenting everything.
You know, one of the most practical things about this guideline is its flexibility. For example, it doesn't give you some rigid definition of what a case is. The panel totally got that you need to balance being thorough with being practical. A lab can decide if a case means one representative slide or, all the slides from an accession, just as long as whatever they choose allows for a really thorough assessment of the system. So how do we wrap all this up? I know it can seem a little complex, but validating your WSI system is actually pretty manageable if you just focus on a few core evidence-based principles.
Look, if you remember nothing else from all of this, remember these three numbers. A minimum of 60 representative cases, a target of 95% or greater intra-observer concordance, and a washout period of at least 2 weeks. That right there is the evidence-based foundation for a confident and safe rollout of digital pathology.
And that really brings us to the final and maybe most exciting point. This rigorous validation, it isn't just a regulatory hoop to jump through or some safety checkbox. It's the gateway. It's what gives you the confidence to truly unlock the future of pathology, enabling remote work, making collaboration easier, and of course, integrating all the powerful AI and machine learning tools that are really set to revolutionize how we all practice.